Welcome to Healthline 3. I'm Jade Balexa. Thank you for joining us. Interventional cardiologist Michael McGalley, who is also a complex coronary intervention specialist at Willis Knighton Cardiology, treats what's called coronary chronic total occlusions or blockages in the arteries. And today we're going in depth on what you can do for treatment and how you can reduce your chances of developing CTO. Doctor, thanks so much for joining me today.
Thank you, Jay. It's a pleasure.
Absolutely. So we have a lot to talk about, but first off, tell me, what is a chronic total occlusion?
So there is a wide spectrum of coronary artery disease, and this is definitely one of the most common causes of death. So coronary artery disease starts by usually just a little bit of a plaque or a little bit of blockage that most people develop because of a lot of things. And on the spectrum, with age and a lot of other factors, it can develop up to being 100% occlusion, which is a total occlusion of the vessel. So mind you, the heart has 3 major arteries, so if one of them is completely blocked, it gets help from the other vessels, but still can cause a lot of symptoms and can cause bad effects on the heart. So a chronic total occlusion is basically 100% blocked artery in one or more of the 3 heart arteries.
Wow. And who may get this? Who may get a total occlusion?
So it is, again, it is in the spectrum of coronary artery disease. So anyone who is, exposed or could have coronary artery disease could have a chronic total occlusion. It gets, the percentage is higher in people who had prior heart attacks, but anyone can get it depending on, the risk factors, including age, smoking, everything else.
Is this primarily genetic?
Like any coronary artery disease, genetics play a very significant role in it, and all the other factors are the factors that we can control, and actually we consider more important. Like, the way we live or diet or exercise, medications we take, all that. But genetics play a very important role in developing severe coronary artery disease, including chronic total occlusions, of course.
Okay. Now, is this something that is more prevalent in a male or female?
So traditionally, we believe it's more prevalent in males, but there is a lot of focus now that we don't want to ignore that it definitely can happen in females. And there is a lot of focus on identifying and treating these conditions in females as well. But traditionally, we believe that it is more common in male.
And what ages do you see this most? Are we talking about the older population?
So traditionally, it is the older population. So because age is a very important risk factor for coronary artery disease. So the more you get older, the more you have a higher risk of developing chronic total occlusion or severe coronary artery disease. Recently, because of different habits and stuff, we occasionally see this in younger and younger population, which is not a good observation, but it is what we're seeing these days.
How young would you say?
Well, I'm talking 30s and 40s.
That is young.
Yeah, not very common, but we definitely have seen it.
And so let's just talk more about the risk factors. Let's go ahead and kind of get that out of the way. So we talked about the age, we talked about genetics. What are some other risk factors?
So the way we usually like to talk about risk factors is categorizing them into those that we can control and those we cannot control.
Okay, let's go through that.
So you cannot control your age, you cannot control your genetics, whatever you get from your family, all that stuff is not controllable. But what we can control is the area of focus, is what we focus on. And this includes a lot of risk factors, but most importantly, we're talking about high blood pressure. It's very important to control that. High cholesterol, which is very important to control that. Smoking, it's also a very bad risk factor. Exercise, very important. All these things, if we can control as much as we can, this is what we can do. But we cannot make someone younger. That's, And
so how common are these chronic total occlusions?
So
How often are you seeing this?
So it is actually pretty common that, but not common in population, but it's common among people with coronary artery disease or people who undergo workup for this, like going in and, for example, having a heart cath or an angiogram because they suspect of that they are having coronary artery disease. It can reach up to 20% of people who undergo these tests. So it is pretty common. It's not uncommon.
So how would someone know if they have it? What are the symptoms?
So again, it lies in the spectrum of coronary artery disease. So the symptoms of coronary artery disease in general include mostly, and most classic is having chest discomfort, like chest discomfort with exercise. Sometimes it happens at rest, but mostly with exercises, walking, doing activities. Other common other common symptom is having shortness of breath, which can be very equivalent to having chest pain. Another symptom that people might not notice right away is that when they start to get these chest pain and shortness of breath with doing activities, they start to limit their activities, so they don't get this. So when they are asked, do you have any chest pain or shortness of breath, they say no, we don't, but that happens because they are starting to limit their activities not to get to the threshold of getting these symptoms. And these are actually the most difficult ones to catch, because the body is smart enough to tell you to not do things that gets you pain, but now you're covering your symptoms basically.
So if you feel that pain, I mean, you should definitely see a doctor. Should you stop the exercise?
So usually if you have pain when you exercise, you definitely should stop the exercise for sure. And seeking help is very important. Not to say that every chest pain or shortness of breath can be coronary artery disease, but it definitely is worth working it up and getting it out of the way, confirming that you don't have it for sure.
And tell me about how chronic total occlusion is diagnosed. How do you guys go about diagnosing someone?
So initially, when someone comes in with these symptoms, there is a set of tests that we do, mainly looking at the heart with an ultrasound, doing a stress test or a CT scan, just to see who would not have it. Like if everything comes back normal, you probably would not have coronary artery disease, and then we look for something else. When these tests suggest that there is coronary artery disease, the next most logical step is doing a heart cath or a coronary angiogram, and that is probably the only way to diagnose the extent and severity of coronary artery disease.
Okay, we have Charles on the phone right now. Charles, good afternoon to you. What is your question?
Well, my question is, I went for a cardiology to check my liver and colon. I came out okay, but they found a calcium deposit in one of my heart arteries. Well, they sent a deal to the VA hospital. I'm a wounded veteran. They sent a deal to the VA hospital that I had a calcium buildup in my heart, one of my heart arteries, and I needed to see a cardiologist. Well, of course, I went yesterday, and they're behind, and they said, well, you got an appointment October 6th. Can you make it till then? I said, well, I'll try. But I do feel a sharp pain every once in a while when I'm really going to town. I'm really busy. I'm 74 years old. I told them I'd try to hold off till I saw the doctor October 6th. He said, anything to worry about.
Well, so Charles, you talk about two different things here. One of them is calcium buildup, and calcium buildup is, in your age, it's pretty common. It's not something that we definitely should be worrying about or treating urgently or anything. It just says that as a part of the aging process, parts of the body accumulate calcium, and parts of this is coronary arteries, and that doesn't mean it's blocked or anything, because the calcium can be outside the vessel. What we do with this is that we check your symptoms and everything. The other part that you're talking about, which is a bit concerning, is you having sharp pains and shortness of breath. And I would ask you this: do you get this just sitting at home? Do you get it all the time? How long have you been having this?
Well, it comes and goes. Sometimes I can just be sitting eating in a restaurant or something. I start getting a little dizzy, but usually the pain don't hit me. It'll be a short pain on the left side up near my breast. And also I've had no voice for about 10 months. I got to find out what that problem is. But the doctor recommended, the oncologist recommended I see a cardiologist to have a stent put in that area. So.
Well, a stent is jumping too much. You just need to figure out what is going on, and if there is something that needs a stent, definitely a stent might be appropriate, but there is a lot of things that needs to be done, including medicines and stuff. And if your appointment, you said in a month?
October 6th.
Yeah, I would, I'm sure your doctor gave you a couple of medicines to keep your blood thin until you make your appointment. And then what I advise you is, if this pain doesn't go away and it lasts for about 20 minutes, you need to go to the ER to get it checked for sure.
All right, so I sure appreciate that.
Thank you.
Thank you, doctor. I appreciate it. Bye-bye.
Thank you.
All right. Well, that was a great question.
Yeah, absolutely. It hits on that symptoms can have a wide range. It can be sharp pain, it can be dull pain, it can be just shortness of breath. Dizziness is unlikely, but it definitely can happen. So all these require attention for sure.
Absolutely. All right. So yeah, make sure you call in if you have questions, 318-219-4569. So are cardiologists the only ones that can check for a chronic total occlusion?
It's actually a very specialized part of interventional cardiology. So to be able to check it, you need a heart cath. You definitely need an interventional cardiologist to do that, to check you for it. And then the treatment options are, definitely should be handled by someone who specializes in chronic total occlusions.
So you use the heart catheter to check for it. What else can be done? What other tests can be done?
So all the other tests are just to suggest should this patient have a heart cath or no. But the heart cath is basically going in with a small catheter to the coronary arteries and shooting dye in the X-ray to see what is going on with the artery. And basically that is kind of the only way to figure out how blocked are the arteries, what is the extent of that, is it 100% occluded, what is going on with the other vessels, all that. So heart cath is basically the only test that can diagnose that.
And talk about exactly how large can these blockages be?
So the extent of coronary artery disease, it can range from like 5-10% blockage, which is we don't do anything for that, we just give them medicines. It can be up to 80-90%, which is needing a stent or surgery, and can be 100%, and that is kind of a different category than the others because it becomes very, very difficult to treat, and that's why it needs a specialist that does that kind of work.
And so talk about what kind of treatment options you do offer patients.
So traditionally, the treatment for chronic total occlusions, because this is so the way people treat coronary artery disease in general is definitely giving them medications to stabilize this, prevent it from progressing, and prevent heart attacks. There is also, which is traditionally has been the go-to before, inventing the stents and all that, is going to bypass surgery. And that's basically bypassing part of the artery, the blocked artery or whatever, the diseased artery, with another bypass from a vein or another artery. And then with invention of ballooning and stenting, which has showed tremendous growth over the past 30 years, we started to treat arteries that are not 100% occluded through passing in through the same catheter. We pass in a wire, we balloon it, open it up, and place in a stent. And of course, it can range from very, very simple to very, very difficult. But it still lies within the stenting part. The problem with chronic total occlusions is that it's not easy to pass a wire because it's chronically occluded. And that specialized niche has grown tremendously over the past 10, 12 years with specialized equipment, specialized wires, specialized some kind of expertise of going to these occlusions from both sides, trying to open them. And because these procedures are tough, long, need special kind of expertise, it defaulted to a certain number of experts that do that.
Okay.
And this is through stenting. Of course, you still can have surgery, you still can have only medications and just decide not to do anything else. But in terms of treating this with the stents, it's still catching up to people because most of the interventional cardiologists, they just do not have enough expertise to treat that.
What services are offered at Willis Knighton?
So we definitely offer treating these vessels through specialized equipment and teams and expertise to open these vessels. Absolutely, with stenting. Of course, if surgery is a better option for that specific kind of patient, surgery is definitely offered. But if it's not appropriate, if the patient's too old, if he doesn't want surgery, all that, there is definitely always the option of treating this with the stents and balloons.
So once it's treated, once CTO is treated, is there a chance that it'll develop again?
That is a great question. So so the answer to this is two things. All right. So developing again in a different vessel or in a different area other than the treated area, it is definitely a possibility. But because when we treat patients and give them stents, we give them a lot of other medicines to prevent that progression, it is less and less likely because we give them the medicines to protect them from developing this. As for the treated area, we have seen a lot of tremendous improvement in stopping recurrence because we now use certain types of ultrasounds that go into the vessels so we can see how we can expand our stent. Again, specialists in this field know how to exactly optimize the results to prevent this from coming back again. So we have seen a lot of tremendous growth to prevent this from happening again. Is there a possibility? Yes, but it's getting lower and lower with everyday inventions.
Because these blockages, they occur over time. I mean, this is over years, right?
Years and years. Years and years, yes. It can be accelerated with having a subtle heart attack, like someone getting pain and then ignoring it, not thinking it's anything, getting over it in a couple of days and then move on with their life. This small tiny event could be a blockage in an artery that develops into 100% occluded vessel that they live with.
Can you take like over-the-counter supplements to maybe help, maybe reduce your chances of developing CTO, or is there anything you can do to maybe change your lifestyle to reduce your chances of this?
So I would go back to the risk factors, right? I would go back to the risk factors. Again, the things that we can control. I mean, there's no specific supplement or anything to prevent coronary artery disease. It's not a thing, but there is a myriad of stuff that we can do to prevent this from happening. And again, the most simple, easy thing is to get your blood pressure. And if it's high, treat it. I meet a lot of people who don't like to take medicines, but if you know the disastrous effect of having high blood pressure for a long time, you would rather take a pill than just letting it go high. Another thing that is extremely important is cholesterol. For a long time, people thought that bad cholesterol of 100 is normal and that's okay and stuff. All the new studies and new guidelines and everything, they say bad cholesterol is not good. The lower you get it, the better, according to your risk, of course. So taking a pill to reduce your cholesterol might be the life-saving grace for you in 20 years. Smoking, of course, is extremely disastrous to the heart arteries. And I would say among the top things that you can do, these three are the most important risk modification that you can do.
Mm-hmm. And I would imagine, being in the South, a lot of us eat fried food. Does that contribute?
Well, it definitely does, but I wouldn't put it. I mean, salt is the most, disastrous part of all that. Fried food contains a lot of salt, so salt increases blood pressure. Blood pressure leads to all that. So I'd say salt in fried food is the most bad thing. There is, cholesterol in fried food. Yeah, there is. But again, cholesterol in our body, 80 to 9% comes up from genetics. So treating cholesterol is with a pill or something is very important. Fried food is not good. Yeah, it's not. But if we take care of the most important stuff, all the other lifestyle changes will come into place.
Mm-hmm. And we have Christy on the phone right now. Christy, what is your question?
Yeah, this is Melba Christie, and I wanted to know, I have been a blood thinner for years now because I had a pacemaker, my body rejected it and all this stuff. But anyway, now I'm on a blood thinner, and at times I have to have blood transfusions because of it. Now they want to put a little apparatus going up through my groin, and I'm just leery about that procedure. So can you tell me more about it?
Well, if I am guessing right, because that's a very broad question, that specifics, if I'm guessing right, we are talking about a device that goes in and blocks a part of the upper chamber of the heart, the atrium, that forms clots with certain kinds of rhythms. And well, this device has shown, I mean, as far as I know, this device has shown a lot of promising results in making people stop blood thinners and at the same time preventing strokes. And the risks of this procedure is not high at all. I think it lies around 1%. There are very good specialists that do this procedure day in, day out, and I think they are the ones that are most fit to do this procedure for you, for sure. But it's known, it's good, it's known to decrease the risk of a stroke and get you to stop the blood thinner so you don't get blood transfusions.
But is there another way to do it besides going through the groin area?
Well, I think that's the easiest way to do it. You don't want an open heart surgery, do you?
No, and I don't want to bleed out either.
Yeah. I think this is the easiest way to do it.
Oh, okay. Thank you, sir.
You're welcome. You're welcome.
Thank you for calling, Miss
Bye-bye.
Christie. All right, we're getting some good questions. And yes, you can call the number on your screen. We still have time, 318-219-4569. So yeah, blood thinners, is that something you recommend if you're someone dealing with the coronary artery disease?
Well, there are a lot of types of blood thinners. I think the type that we give for coronary artery disease is different from what she's taking.
Okay.
And we're basically talking about at least baby aspirin. And that definitely depends on the patient, what they have stents before, are they just using something to prevent it, and all that stuff. But I would not recommend off the bat taking baby aspirin over the counter just to prevent coronary artery disease. This has not shown a lot of promise except when you are very high risk. We have actually done a very big study in the Journal of American College of Cardiology about 3 years ago about taking that aspirin. We've shown that, if you just take baby aspirin without recommendation from a doctor, you might be hurting yourself.
Mm. Are there any other medications that you guys recommend when dealing with total blockages?
So in general, that depends on what patients come in with, because a lot of patients, they say, well, I know I have this, I don't want to get any procedure at this point, or I need to wait until I think about it. So the main medicines that we give are medicines that try to get the heart to accommodate the lack of blood flow. as much as possible without getting symptoms. So they are treating the symptoms of the blockage. And there are like 3 or 4 classes of these medicines we use frequently to make patients feel better. And mostly if they feel better and they don't want to go any like invasive treatment, that is also a very good treatment strategy, depending of course on every specific patient.
Mm-hmm. And tell us a little more about your title, your interventions cardiologist. Specifically, what does that mean? What does all your title entail?
So basically, interventional cardiology is a branch of cardiology that deals with specifically treating patients with procedures, patients who need procedures. And my kind of specialty in complex coronary artery disease is, as I mentioned, people who have like 70, 80, 90% lesions, interventional cardiologists treat this with wiring balloons and stents, and it gets more complex when these blockages have a lot of calcium, when they are at a bifurcation or an area where it's very, people traditionally are told this is tough to stent, or this is not stentable, or we cannot do this. The field or niche that I specialize in is treating these kind of diseases that people are told, well, this is not doable. No, in 2023 we have made almost everything doable.
Mm-hmm.
And the top complex lesion of all this is chronic total occlusion, which is not everyone can do, of course.
Mm-hmm. Wow. So are you the only one at Willis Knighton?
No, there is a good team that has been practicing for a while. I did a specific training in this, so I have some certain kind of new skills that have been out. I spent a year training in chronic total occlusion in Henry Ford Hospital, and this is one of 5 training programs in the country.
Wow,
for this.
That's incredible.
Yes, so we've been exposed to the most new, techniques to treat these kinds of specific, very, very difficult patients that are usually rejected by most people across the country.
Mm-hmm. Well, thank goodness for people like you who can help people who have complex situations like that, complex blockages. So tell us, if people need more answers to their questions, how can they reach you?
I think you guys will put in the number they can call to make an appointment at Willis Knighton Bossier, and I can see them there and we can talk about anything.
Yeah, okay. All right, well, you've been great coming on to talk about this. And is there anything else you want to add to keep people healthy and out of the hospital?
Well, I'd say the most important thing is just watch your lifestyle, and don't be afraid to take medicines when they are indicated, and don't ignore symptoms. Don't ignore your chest pain, don't ignore your shortness of breath, get it checked.
Mm-hmm. No matter your age, right?
Yes.
Yeah,
absolutely.
Because you were talking 30s and 40s you're seeing patients.
Yeah, not to scare people. It's not very common, but it
Yeah.
definitely can happen.
Yeah, definitely.
Yeah.
Well, thank you so much. I appreciate you coming on.
You're welcome. Thank you, Jade. Appreciate it.
All right. And remember, you can see all our Healthlines at ktbs.com. And this has been a great addition to talk about these occlusions that do happen. And we'll have more Healthlines next week. So definitely join us.